So this is the time for questions, and for we have mics out in the audience, and the folks with mics are going to raise their mics so that our videographer knows where to go.
We usually see our patient the pain patient with the regular patients. Do you recommend to group the pain patients together as like one half-day clinic or one-day clinic so that you'll be able to be more effective dealing with that? Or should they just be in the mix of other kind of patients as well?
So we've done group visits for about, I don't know, 8 years now, and I think it's preferable. They're skills-based, so we actually have, I can send you the curriculum if you want it. It's a 12-week program called the Pain Resiliency Program, and it's run by our occupational therapist, but we'll have other people come in. And then there's, so one, it's skills-based, and it's, people spent lots and lots of time processing, and what's the Bessel van der Kolk thing? Like, yes, less yakking, more action. I think people just realize, like, we also thought they just need more skills and practice with the skills. So there's that emphasis. And then I can't say enough about the role of peers in providing patients both with feedback, but also if you've got some real standouts, some of your patients who are doing really well, it's great to have them in the room. We, for quite some time, tried to have the provider as part of that visit, and then if there was pain medication prescribing, kind of pulling people out or handing out prescriptions at the end. We still do that to a certain degree. I've actually found it's more effective for people to be in groups where that is really the focus of the experience, and then they're just checking in with you outside of the groups. But it's kind of understood that enrollment in the group is predicated on receiving prescriptions if that's part of what you're trying to achieve.
I'm not sure, Will, but were you asking if you should lump your patients together into one half day? So like some of our urgent clinics or primary care clinics will say, oh, let's make this half day all peds or OB visits. Or does it make sense in a busy multi-patient clinic to say, let's make this a pain half day where all the pain patients come in, sit in the waiting room together, but you see them one by one?
We haven't tried that model. Again, I'm not, we did originally, frankly, and so that we could have a much more planned care kind of visit. People were getting urine drug screens. It was a planned visit. Urine drug screens, any other kind of screening you were doing. I'll be honest, this is totally not the appropriate thing to say. It felt like a juice bar. Like, I just felt like they're coming in, we're doing this stuff, we're doing prescriptions. I didn't feel like those were really substantive interactions. I think the focus, if you're trying to consolidate effort, should be on what are the skills and the reinforcement that people are getting and what's the best space in which that happens, as opposed to what's more efficient for us as a practice.
And I think it really depends on your clinic. So folks from Emmeline and Wattsell may have heard me talk. I advocate for the buprenorphine patients to try to do it in the same time period, because you can help manage the expectations of all your support staff. Like, hey, this is the morning the buprenorphine folks are coming. Everybody's gonna they wanna pee right away. So what can we do to facilitate that? And if there is any staff kind of negative countertransference turn this patient group, you can kind of work on it and address it. Maybe you need to have more social workers available that morning to kind of help manage a patient who's irritable or upset about something that's going on. But I really kind of depends on your setting. I would also say I'd hate for patients to feel stigmatized because they're on a certain day. You may want to normalize them, but sometimes it does help to pool all your resources around a particular time.
Question. So here we're talking about people who are actually coming into clinic. My question is about someone who was at Stanford at a 72-hour hold, went home, said, yeah, I'm going to go see the doctor, has been doing heroin and methamphetamine for maybe 2 or 3 years. How do we get him back to seeing the doctor? Who's going to coax him and how? And what are the techniques that one would use for that as far as the family is concerned?
I mean, I think you're talking about outreach, right? And I think that really is a whole nother topic that we weren't talking about. But I do thank you for that question, because I do think that's so important. And it's not just somebody who's been on a hold, right? It's the same folks who are in too much pain to go into the doctor. You know, they just want just give me my refill or my prescription, and I think that can be challenging.
Yeah, we also tend not to focus on outreach, but focus on the existing wait list of patients who are ready to engage in treatment or are requesting that. But I think one resource that comes to mind is a book called Getting Your Loved One Sober, that it's Bob, the partner of the person who developed CRAFT and CRA. No, it'll come to me. But Getting Your Loved One Sober could have some resources for the family around that, about getting them ways to help them motivate the patient to come in to seek treatment.
We do a lot of outreach, again, in our organization, particularly because we take care of a lot of homeless individuals. I'm hesitant to throw my I don't know how the benefits and things in Oregon may be different, but we use a lot of peer recovery mentors, which at least for substance use disorder services in Oregon, is a billable service. So if there is an outpatient program in particular, that peer recovery mentor can be embedded within that outpatient program. We also have peers within our detox center, and those are the individuals that are going out and trying to connect with people. It's helpful if there's another entity which is helping you manage that information. So if it's the health plan saying, you know, if there's something about that individual that's flagging something for the health plan, and they're pushing out a list of people either who are, you know, recent overdose in the emergency room, or obviously a high cost, high utilizing individual, those are the types of lists we've talked with our health plans about pushing out. And then we have a tool called Pre-Manage. I don't know if you all have that here, but then lets us look at where that other person has been and even be able to embed some notes in this this thing called the Emergency Department Information Exchange, which then flags the emergency department that we're trying to find this person. So those are resource-intensive efforts. But if what you're finding is that this is a critical enough problem within your community, it sounds like you have organizations where you have a lot of different players at the table, from hospitals to the county to health clinics to payers, who can try to do some problem solving around that.
Meet the Health Improvement Partnership, and that this might be a good topic in terms of outreach. I also really love the emphasis on peer and recovery mentors. I would love your materials. Please do send them, and we'll send them out to folks. Do you want to? I think Vanessa wants to say them.
And then in Santa Cruz, this is for folks who show up in the CSP, which is the Crisis Stabilization Program for someone with on a mental health hold. We do have a program now called Rapid Connect, and every patient who presents there, they're called afterwards, you know, whether or not they're a Medi-Cal patient, even if they have commercial insurance, and then are given some care coordination assistance and sort of what is that next step? What did they need to connect with? I mean, it's not the only answer, and obviously doesn't address the medical ERs, but we realized there was quite a need for that.
So my question is probably everybody's question. I see few patients actually on opioids, but I do see some. What I see so much more of are alcoholics, meth addicts, and marijuana addicts, and all of which affects the ability of the medications I'm giving them to function. And given that buprenorphine seems like it doesn't deal so much with pain and more with the addiction cycle and the neurotransmitters and the upregulating, is there any way that that could be used for other types of addictions? Is there any evidence about that?
Say the last part of your question.
Is that given that buprenorphine deals with the cycle and the, you know, modulating the D2 so it doesn't over or poop out, but all of addiction has kind of a similar feedback. Does buprenorphine work for other addictions? Is there anything else similar?
I mean, so I spoke primarily about the medicate for alcohol and buprenorphine. We don't have great medications for the stimulant or for the cannabis. It's true. And there's some studies out there, but it just hasn't borne out that much. So I think that can be challenging. I think the other piece around buprenorphine and methadone is that they're safer versions of the drug of abuse, where we don't. It's with methamphetamine, and so there are some studies doing with HIV positive men who are amphetamine addicts, and I think they were pairing putting them on some sort of long-acting stimulant, pairing it with their ARV therapy, and there was some efficacy there, but they were tying it to something else, and it was reducing their risk. When I was at the VA, we found a few folks really advocated that they had done well on Ritalin or Concerta or some extended release amphetamine, but even within the context of our program, it became problematic. Like they were harassing the nurses, asking for increased dose, exhibiting some of their old behaviors. So it's hard to make that work. I wish we'd had a safer form of those drugs that were helpful.
Well, I think it's a really interesting question, the second half about using buprenorphine to sort of quiet the reward pathway. My own clinical experience, I've done just addiction medicine for the last couple of years, is that for patients who've had opioid use disorder and severe alcohol use disorder, they can do great on buprenorphine, but they're still drinking. I think some of that is that there's a lot of other things that get upregulated. Glutamate in particular gets really upregulated as people have more severe alcohol use disorder. So I've often found that a combination therapy using buprenorphine and then maybe gabapentin for alcohol use disorder has been more successful. I think it's a fascinating question, but I also think there's probably with other drugs of abuse, there's other neurobiological things happening that just affecting that reward pathway alone wouldn't be sufficient.
I don't know if this is a neuroscience question, but my question is for people who I work with co-occurring disorders, and so somebody will be abstinent for a while and then they'll have some major surgery and be prescribed Percocet and I wonder how they're able to take it without it, making them go through the whole addiction process again, because they do take it for the pain after having surgery, but I guess my question is, how is that possible, and if there's any other alternatives?
So there are guidelines around what to do if somebody who's on buprenorphine needs to have surgery. And it used to be you had to taper them off 5 days before the scheduled procedure, and sometimes you might treat them with another opioid. But really right now is if they just don't take their buprenorphine the morning of the surgery, they should be treated with whatever the standard pain meds are while they're in the acute phase. And then they should be, as quickly as possible to end those, pain meds so they can get back on their buprenorphine. And ideally you'd have very close communication with the buprenorphine provider and the team that's doing the surgery and managing the patient post-op, because this is highly triggering. I mean, it's gonna be a period of their recovery is vulnerable. They're high risk. And so kind of what supports need to be there to kind of help them through. I mean, you could say a surgery is high risk for someone who's been struggling with depression and is in remission from depression. Sometimes, the anesthesia and the pain can, knock them into a depressive episode. Just kind of that same approach of what can we do to build up and support them through this time that we know that's going to be hard.
There's also, you have a resource here. There's a anesthesiologist named Andrea Rubenstein. I think she's down in Santa Barbara. I've seen her talk.
Santa Rosa.
Yeah. And she's actually looked at, not in sort of prospective trials, I think from her own clinical experience, if people are maintained on their buprenorphine, even day of and throughout, that their overall opioid analgesic needs are dramatically lower. So I think you've got a couple of, I think you've got a couple of options there. It's probably, particularly if you're working in a hospital where they're more familiar with buprenorphine and that kind of thing, that second option may be more viable. What Vanessa's recommending is probably going to be more viable, particularly in a hospital where they might be a little more freaked out about it.
Yeah, we are trying to educate our physicians at Dominican Hospital, and I don't know what's happening in Monterey, but I think, and Andrea actually came and presented with us here at one of our CMEs, but thank you for those two different options.
And the bottom line is that especially for an elective procedure, that the person should still be considered a candidate. You'd hate to say, I mean, I've had patients tell me that the orthopod told me no, because, you know, and that's just a shame.
So I think we have like 1 minute. Is there a short, okay, right here.
With changes, certainly in the state with the use of cannabis, as a primary care internist, I feel woefully uneducated and unprepared by professional organizations and my specialty and everybody in terms of what to expect. And given the fact that a lot of my 80-year, 90, even 90-year-old patients are getting cannabis products from their friends and relatives, and given the fact that online, I even read that CBD products are being have sugar and flavoring to appeal to children, I was just wondering, has anybody tried to anticipate the effects of changes in the law and usage by the general population, how that will impact any of the things you have been speaking about today? Thank you.
You don't have this problem in Oregon, do you?
Sure. So is recreational cannabis legal here now? Yeah, okay. So it's been legal in Oregon for, I guess, 1.5 years. And I think the best lessons we have are from Colorado, where it's been legal for longer. And I think, I mean, from a public health standpoint, I just saw a talk by their state public health director. This was 1 year or 2 ago, so my memory isn't great. But certainly, particularly emergency department visits for children had a dramatic spike. The public health, or an emergency room physician also talked about this increase he was seeing in, Denver is a big hub, you know, as an airport. So they used to have lots of referrals to the ED for too drunk to fly, and now they're getting lots of too stoned to fly. Like people were buying all of their edibles or whatever it is, and then they were worried to bring them on the plane, so they were eating them all. So I think you'll start to, and then they'd end up in the emergency department. So I think certainly from for the populations that you're referring to, I think our biggest lessons are probably from Colorado in terms of looking at what the impact on young children has been. I would say, to just take the question a slightly different place, and again, I haven't done straight primary care for a couple of years, but the options for other routes of cannabidiol for CBD, particularly as people are coming off of pain medications, and particularly for people who have really profound contraindications to opioids, and they're using some of these other tools, that it's been, again, and I don't know enough about it to recommend, so I think that's part of the deficit in knowledge there, but they are sort of seeking out other options, particularly topical CBD, and they're saying, you know what, I'm not having side effects, my function is improving. You can see and they can demonstrate their function is improving. This is not an evidence-based comment, again, and I'm not able to sort of quantify, here's the right amount for people. There are physicians who are better at that, but there is a therapeutic window there, particularly around CBD, that I wouldn't discount.
I would say that this is challenging in terms of working with patients. If it's not in a therapeutic window, for example, and it is problematic, I've found that motivational interviewing can be a tool to go to, but it is much more challenging for the patients who are coming in with those issues because the rewards feel more salient and the risks and negative consequences feel much lower, is my experience of individuals coming in, that there's just not the same consequences with other use that they perceive. They feel like, oh, I just smoke weed and it's not a problem and it actually helps me in XYZ ways. But if it does feel like, there could be some benefits in shifting that use, just trying to get at any concerns that they might have. So, sometimes I'll just ask, what's your concern about smoking the way that you are right now, long term? Or, it sounds like, or you can do what's called an amplified reflection, where you exaggerate it more. So it sounds like weed's not causing any problems at all in your life. And they'll say, well, no, that's not quite true. My memory's not so great, or it's hard to drive, and so then just trying to kind of build on those kernels that they might offer. But I do want to acknowledge that it is much more challenging working with those patients, and getting them motivated to make a change around that particular substance use.
And I think with the legalization and kind of removing that social censure also makes it really hard. Like, people get it if you messed up and you had a hard time that you shouldn't drink, for example, and people might be respectful and will serve you soda at the party or something. But it's especially in many of our California counties, that's just not the case. So it's just very challenging if it's kind of part of the fabric. I think from a legislative perspective, again, because we're so decentralized and each individual county is going to be making and cities will be making different decisions. That can be challenging in terms of, there might be ordinances against or for various things, like no gummy bears, which I think would be a good one. But when I was at the VA, they had to deal with this because it's a federal system and every state is different. And I felt this perspective was helpful in that their rules were VA MDs could not prescribe marijuana because it's illegal per federal law. However, in terms of your patient in front of you, you weren't allowed to discriminate against the patient just because they smoke marijuana. So, for example, you couldn't kick them out of your program, your pain program, your rehab program, your nursing home, or the like. However, it was required that all VA physicians, if you knew your patient was smoking marijuana, that you had a discussion about the risks and benefits, and that you advised the patient and documented your concerns. And so they did kind of do a massive education about what all those risks, the medical risks are, the withdrawal risks are, and that you had that discussion with your patient. And then you go right to what Alexis was talking about, is trying to find what part of their use might be a problem for them and work with that. But I find it can be really hard to quit. There's not as many, there's AA, there's NA, there's a lot more out there for people.
But this is an important topic, and maybe if we can find someone with a lot more knowledge about cannabis, that might be appropriate for this setting in the future.